Welcome to our video on the pharmacology of the renin, angiotensin, and aldosterone system, commonly referred to as RAS. After watching this video, you should be able to discuss the regulation of the classical renin-angiotensin-aldosterone system, pathophysiological roles of RAS, different pharmacologic agents targeting RAS, and special uses of RAS inhibitors. You should also be able to select specific RAS inhibitors in different clinical scenarios and identify adverse effects of RAS inhibitors. The renin-angiotensin-aldosterone system, or RAS, exists both as a circulating system and locally at the tissue level. At the tissue level, RAS can act as a paracrine, autocrine, or intracrine hormonal system, where it affects adjacent cells, its own cell externally, or within its own cell respectively. The circulating system is responsible for maintaining hemodynamic stability with acute blood pressure changes, peripheral organ perfusion, and prevention of hemodynamic collapse. At the tissue level, RAS is responsible for long-term tissue growth and function. Both the circulating and tissue systems share similar pathways for the synthesis and degradation of key players. In this video, we will discuss the basic renin-angiotensin-aldosterone system in circulation. In circulating RAS, we start out with the constitutive hepatic synthesis of angiotensinogen. Renin is an enzyme synthesized and released by the kidneys. Renin synthesis is stimulated in response to glomerular hypoperfusion, i.e., when there is decreased arterial blood pressure, sympathetic nerve stimulation, or decreased chloride delivery to the macula densa in the juxtaglomerular apparatus, JGA. Renin catalyzes the rate-limiting conversion of angiotensinogen to angiotensin 1. Angiotensin 1 is subsequently converted to angiotensin 2. This reaction is catalyzed predominantly by a carboxypeptidase enzyme known as angiotensin converting enzyme, or shortened as ACE. ACE has been identified in lung tissue, neuroepithelium, plasma, and vascular endothelium. Angiotensin 2 exerts different physiological effects by binding to different receptors, namely AT1, AT2, and multiple others. The binding of angiotensin 2 to AT1 receptor induces tissue hypertrophy, proliferation, and fibrosis. It can also facilitate thrombosis and induce vasoconstriction, aldosterone and vasopressin release, a pro-inflammatory state, and increased sympathetic nerve activity. So what are the clinical effects of aldosterone? Aldosterone can mediate sodium retention, which can lead to fluid retention and hypertension, potassium and magnesium wasting, which can be arrhythmogenic in at-risk individuals, pro-fibrogenic and thrombotic effects that can lead to tissue fibrosis, thrombogenesis, vascular inflammation, and endothelial dysfunction. As it turns out, ACE is also involved in another set of hormonal system called the kallikrein-kinin system. Similar to RAS, the kallikrein-kinin system is also present in both circulating and tissue systems. Briefly, this system starts out with kininogen to form bradykinin with the help of the enzyme kallikrein. Bradykinins mediate vasodilatation via stimulation of nitric oxide and prostaglandin formation. Bradykinins also inhibit renal sodium and water reabsorption, among others. These effects are antihypertensive. However, in the presence of ACE, these cardiovascular benefits of bradykinins are lost. This is because ACE also inactivates bradykinin. A few more words about bradykinin. As previously mentioned, bradykinin mediates vasodilatation via the stimulation of nitric oxide and prostaglandin formation and natriuresis, all of which are good effects to have against hypertension. Unfortunately, bradykinin does have its bad side. Bradykinin also plays an important role in pain perception and inflammation associated with tissue injury. With tissue injury, bradykinin mediates enhanced vascular permeability, which causes tissue swelling, stimulation of sensory nerves and nociception, or perception of pain, contraction of visceral smooth muscle, and release of inflammatory mediators. Fun fact: aloe vera contains an enzyme that breaks down bradykinin. This is thought to be the mechanism whereby aloe vera eases pain and inflammation associated with tissue injury. Dysregulated RAS activation may lead to potentially serious adverse outcomes in patients with myocardial injury. In patients with myocardial infarction or injury from whatever reason, there is reduced cardiac output and systemic arterial pressure. This leads to activation of RAS, sympathetic nerve activity, and release of vasopressin, all acting together to increase vasoconstriction and salt and water retention, to increase blood volume and pressure as needed by the body. However, this compensatory increase in both afterload and preload force the heart to work harder to pump out blood. This may cause more cardiac strain and injury, thus creating a vicious cycle of neurohormonal activation, requiring a higher and higher and higher cardiac workload and eventual decompensated heart failure. Similarly, dysregulated RAS activation may also lead to potentially serious adverse outcomes in patients with kidney injury. In patients with kidney injury from whatever reason, there is reduced glomerular filtration. This leads to activation of RAS to increase glomerular filtration pressure and salt and water retention, to increase blood volume and pressure as needed by the body. However, this compensatory mechanism leads to intraglomerular hypertension, remodeling of injured tissue, parenchymal proliferation, and fibrosis. This worsens kidney injury, thus creating a vicious cycle of neurohormonal activation that leads to a more rapid decline in kidney function and eventual kidney failure. In general, angiotensin II can lead to adverse effects to the entire cardiovascular system. Binding of angiotensin II to AT1 receptors can lead to a multitude of untoward effects, including atherosclerosis, vasoconstriction, vascular hypertrophy, endothelial dysfunction, left ventricular hypertrophy, fibrosis, glomerular hyperfiltration, proteinuria, sodium retention, and glomerular sclerosis, among others. All of these work in concert to cause increased risk of stroke, hypertension, myocardial infarction, heart failure, kidney failure, and overall reduced survival. Let's see how we can block the overactivated RAS system to inhibit its untoward effects. We can first try to block the angiotensin converting enzyme ACE. Blocking ACE inhibits the formation of angiotensin II and its downstream untoward effects upon binding to AT1 receptors. Blocking of ACE also inhibits the breakdown of bradykinin, which provides us with these beneficial effects of bradykinin on the cardiovascular system. Commonly used ACE inhibitors include the following. There are important pharmacologic differences among these agents. Whether the drug is active in its native form or function as a prodrug. Biotransformation occurs primarily in the liver. In patients with congestive heart failure and concomitant hepatic congestion, captopril and lisinopril, which are active in their native forms, may have more predictable pharmacokinetics. Another important difference is the route of elimination. Most are excreted by the kidneys. Exceptions are lisinopril and benazepril, which have more hepatic excretion, which could be problematic in patients with hepatic congestion, but may be of use in patients with renal insufficiency. Ultimately, the choice of ACE inhibitors is influenced by many factors: institutional availability, history of intolerance to one particular agent, duration of action and time to onset, and route of excretion. What are the common clinical uses of ACE inhibitors? ACE inhibitors may be used in patients with congestive heart failure, acute myocardial infarction, and mitral and aortic valve regurgitation. ACE inhibitors reduce systemic arterial resistance, thereby improving cardiac forward flow and lessen cardiac workload in all of these cases. ACE inhibitors are also used to reduce glomerular filtration, thereby lowering renal workload and fibrotic changes. These agents are also beneficial in lowering proteinuria via lowering of glomerular filtration pressure and alterations in the integrity of the glomerular basement membrane. They are also commonly used to treat hypertension and secondary stroke prevention. ACE inhibitors may have adverse effects. These include hyperkalemia, hypotension, increase in serum creatinine, and increased risk of kidney failure in patients with poor kidney function, poorly controlled diabetes, or severe bilateral renal artery stenosis, fetal morbidity and mortality if used during pregnancy, particularly if used after the first trimester, and include neonatal skull hypoplasia, kidney failure, an atrial or ventricular septal defect, coughs, angioedema, and others including rash, neutropenia, liver failure, and taste disturbances. What do we expect to see on an EKG as serum potassium increases above normal range? We start with a normal EKG. As serum potassium increases, typically above 6 milliequivalent per liter, peak T wave may be seen, followed by prolonged PR interval and loss of P wave, widened QRS interval, sine waves, followed by ventricular fibrillation. ACE inhibitor-induced cough is not uncommon. It is more commonly seen in women, non-smokers, and Chinese in origin. It has been reported to occur in upwards of 30%. The exact etiology is not clear, but it is predominantly thought to be mediated by the buildup of bradykinin. It is thought that bradykinin induces sensitization of airway sensory nerves, which causes airway smooth muscle constriction, which leads to bronchoconstriction and coughs. The management of ACE inhibitor-induced coughs include discontinuation of the medication or switch the medication to an angiotensin receptor blocker. In some patients, the cough may resolve within a few months. How do we best use ACE inhibitors? Make sure patient is not volume depleted or hyperkalemic before starting any inhibitor involving the renin-angiotensin-aldosterone system. As with any medication, starting out at a low dose is a good idea. In hemodynamically tenuous patients, we sometimes use what's called a captopril titration, where we slowly increase the dose of the short-acting captopril as safely tolerated by the patient's blood pressure. ACE inhibitors may be used in combination with a diuretic, such as chlorthalidone, in the treatment of hypertension to minimize any potential hyperkalemic effect. Great care must be given when an ACE inhibitor is used in patients with reduced kidney perfusion, including patients with advanced CKD, bilateral severe renal artery stenosis, severe aortic stenosis, concomitant aggressive diuresis, problems with hyperkalemia, and concomitant use of any medication that can also increase serum potassium levels, such as potassium-sparing diuretics, angiotensin receptor blockers, or NSAIDs. Finally, monitoring for increase in serum creatinine and potassium within 7 to 10 days in patients with advanced CKD is recommended. ACE inhibitors are great drugs, but there are a few very serious contraindications that must be mentioned. These include their use at any stage during pregnancy, including breastfeeding period. The latter because the medication can end up in the mother's milk and passed on to the baby. Hypotension, hyperkalemia, hypovolemia, known history of angioedema on any RAS inhibitors, and history of intolerance to these medications. Blocking RAS with ACE inhibitors has limitations. First, angiotensin II is not all bad. It does provide beneficial effects when it binds to A2 receptors. These include anti-proliferation, antifibrosis, apoptosis, and vasodilatation. Second, blocking ACE alone does not mean that we can block the formation of angiotensin II completely. There are other enzymes that can catalyze the conversion of A1 to A2. In addition, there are also enzymes that can convert angiotensinogen directly into A2. This brings us to the next inhibitor of the renin-angiotensin-aldosterone system. We can pick and choose and more specifically directly block the bad effects of angiotensin II by blocking AT1 receptor. This would leave behind the beneficial effects of angiotensin II upon binding to AT2 receptor. However, if we only block AT1 receptor, ACE will be left alone to freely break down bradykinin. What this means is we will lose the beneficial effects of bradykinin on the cardiovascular system. Commonly used inhibitors of AT1 receptors, more commonly known as angiotensin receptor blockers or ARB, are shown in this table. Selection of an ARB generally depends on availability and cost. Indications for the use of ARB are similar to those for ACE inhibitors. An advantage of using ARB over ACE inhibitors is the reduced risk of developing coughs and angioedema. This is presumed to be due to the continuous breakdown of bradykinin by the uninhibited ACE. While it is common practice to switch an ACE inhibitor to an ARB in patients who develop coughs on an ACE inhibitor, extreme caution must be given in doing the same for patients who develop angioedema with an ACE inhibitor. There have been case reports of angioedema following ARB switch. Adverse effects are similar to those seen with ACE inhibitors, except for a lower risk of coughs and angioedema. Optimal uses and contraindications for ARBs are similar to those for ACE inhibitors. How can ACE inhibitors or ARB precipitate kidney failure in a patient with pre-existing renal hypoperfusion? Let's take a look at a glomerular capillary. We have afferent and efferent arterioles and normal glomerular plasma filtration. Under normal conditions, vasodilating prostaglandins keep the afferent arteriole dilated to receive blood inflow while angiotensin II keeps a strong vascular tone in the efferent arteriole to ensure good intraglomerular pressure needed for good glomerular filtration. When there is renal hypoperfusion, as seen with hypovolemia, reduced cardiac output, severe renal artery stenosis, or the use of NSAIDs or any agent that can cause afferent arteriolar vasoconstriction, the blood flow going into the glomerular capillary is reduced, which results in reduced glomerular filtration compared to that in the normal state. Now, if we use an ACE inhibitor or an ARB in a patient with pre-existing renal hypoperfusion, we dilate the efferent arteriole because angiotensin II normally keeps it vasoconstricted. The intraglomerular pressure will now be further reduced. This leads to reduced glomerular filtration. The distal pressure at peritubular capillaries supplying the renal tubules will also be reduced. This can lead to renal ischemia, acute tubular necrosis or ATN, and kidney failure. This photo shows muddy brown casts that may be seen in the urine of patients with ATN. One limitation that is common to the use of ACE inhibitors and ARBs involves a phenomenon called aldosterone escape. What aldosterone escape means is that although aldosterone release is initially suppressed with the use of ACE inhibitors or ARBs, the reappearance of aldosterone can be seen with long-term use. This can be problematic. Recall aldosterone can lead to fluid retention and contribute to hypertension, potassium and magnesium wasting leading to increased arrhythmogenic risk, and end organ tissue fibrosis and thrombosis. Aldosterone escape has been attributed to angiotensin III stimulation of aldosterone release from adrenal glands. Angiotensin III is cleaved from angiotensin II by aminopeptidase A. Further RAS inhibition can be done at the aldosterone level. Aldosterone antagonists, also known as mineralocorticoid receptor antagonists, are competitive antagonists that block mineralocorticoid receptors found in various tissues, including brain, myocardium, vasculature, and kidneys. Clinically available agents include spironolactone, eplerenone, and finerenone. Clinical uses of mineralocorticoid receptor antagonists include the treatment of difficult-to-treat hypertension and heart failure, hyperaldosteronism, reduction of proteinuria, combined use with a potassium-wasting diuretic, such as in combination with a loop diuretic in hypervolemic states, such as cirrhosis, heart failure, or nephrotic syndrome, and congenital conditions associated with hypokalemia, such as Barter's and Gittleman syndrome. As with the use of any RAS inhibitor, the use of MRA can also lead to severe hyperkalemia. Make sure to closely monitor serum potassium levels. Do not use MRA in patients with hyperkalemia, and use MRA with great caution in patients with advanced kidney disease because these patients are very prone to developing hyperkalemia. MRA may also be used in combination with an ACE inhibitor or an ARB for synergistic antiproteinuric and antifibrotic effects. Always start at lowest dose and increase as safely tolerated. The most common limiting factor for the use of MRA is the presence of hyperkalemia. Adverse effects of MRAs include hyperkalemia, gynecomastia, mastodynia, erectile dysfunction, and abnormal vaginal bleed with the use of spironolactone, because spironolactone can also bind to sex hormone receptors. Eplerenone and finerenone are selective mineralocorticoid receptor antagonists that do not cause similar problems. Other side effects include granulocytosis, cholestatic, hepatocellular toxicity, gastritis, ulcerations, nausea, vomiting, cramping, diarrhea, and rash. Up to this point, we have discussed blocking RAS from the level of angiotensin 1. What happens if we block renin at the top? Would it be better? Aldosterone is a potent competitive inhibitor of renin. In animal studies, it has been shown to reduce left ventricular hypertrophy comparable to the ARB valsartan and provide equivalent renal protection in a diabetic model in terms of proteinuria when compared to ACE inhibitors and ARBs. In human trials, aldosterone has been shown to similarly provide antiproteinuric and antihypertensive effects as do ACE inhibitors and ARBs. Major side effects include hyperkalemia and diarrhea with high doses. What would happen if we use a combination of RAS inhibitors, such as the use of an ACE inhibitor or ARB with a mineralocorticoid receptor antagonist? All RAS inhibitors provide antiproteinuric, antihypertensive, and antifibrotic effects. While beneficial effects may be synergistic, serious side effects including hyperkalemia, hypotension, and renal dysfunction are also potentiated with combination therapy. Risk and benefit ratio must be carefully weighed. A combination of an ACE inhibitor or ARB with a mineralocorticoid receptor antagonist may be used to treat heart failure, proteinuria, or difficult to treat hypertension in patients with low risk for hyperkalemia, hypotension, and kidney injury. However, these patients must be followed closely for adverse effects, including hyperkalemia and kidney injury. A special note about entresto as it relates to the renin-angiotensin-aldosterone system. Entresto is a combination drug made up of an ARB, namely valsartan, and a neprilysin inhibitor, namely sacubitril. This combination drug is commonly referred to as an ARNI. The use of entresto is currently being recommended in the management of patients with heart failure. So what was the rationale behind the formulation of this particular drug combination for use in the treatment of heart failure? Going back to our RAS system, we have angiotensin 1 getting converted to angiotensin 2 by ACE. Angiotensin 2 binds to AT1 receptor to induce all of these end organ effects to result in increased sodium and water retention, increased sympathetic nerve activity and vasoconstriction, all leading to increased cardiac workload. In a patient with existing heart failure, all of these effects can be detrimental. Fortunately, we do have other neurohormonal systems to counteract these effects. We have A, B, and C natriuretic peptides that can induce natriuresis, and substance P and bradykinin that can induce vasodilatation, all work together to reduce cardiac workload. These natriuretic peptides, substance P and bradykinin, however, can be inactivated by an enzyme called neprilysin. This would then lead to increased cardiac workload. Neprilysin, however, is not all that bad in the setting of heart failure because neprilysin also inactivates angiotensin 2. What happens if we block neprilysin with a drug called sacubitril? A neprilysin inhibitor would prolong the half-lives of natriuretic factors to allow for natriuresis, as well as prolonging the half-lives of substance P and bradykinin to allow for a vasodilated state, all working to decrease blood pressure and myocardial workload. However, because neprilysin also inactivates angiotensin II, a neprilysin inhibitor would increase angiotensin II levels. To block angiotensin II, we could choose to add either an ACE inhibitor or an ARB. Since neprilysin already increases bradykinin levels, thus increased risk for angioedema, which agent would be best to add? An ACE inhibitor or an ARB? It would be an ARB because an ACE inhibitor can also increase bradykinin level, thereby worsening angioedema risk. This is why valsartan was chosen instead of an ACE inhibitor to be used in combination with the neprilysin inhibitor sacubitril. The neprilysin inhibitor sacubitril and the ARB valsartan makes up the combination drug entresto. What do we know about entresto? In the paradigm study comparing the use of ARNI versus the ACE inhibitor enalapril in patients with heart failure, entresto was shown to provide a 20% reduction in primary outcome of cardiovascular death or heart failure hospitalization and 16% reduction in all-cause mortality. Symptomatic hypotension was more common with ARNI, but not associated with worse kidney function. Of interest, the number of angioedema was higher with ARNI compared with enalapril, but this was not statistically significant. Finally, because the neprilysin inhibitor sacubitril can increase bradykinin, thus the risk for angioedema, the concurrent use of an ACE inhibitor is contraindicated because ACE inhibitor can also increase bradykinin. This is the reason why there should be a drug holiday for patients who use an ACE inhibitor for at least 36 hours to make sure all ACE inhibitor has been cleared from the body prior to the initiation of entresto. So far, we have only discussed the negative effects of angiotensin II and its pharmacologic inhibitors. On December 21, 2017, Giapressa, a synthetic angiotensin II vasoconstrictor, was approved by the FDA to be used as a non-catecholamine vasopressor in conjunction with catecholamine vasopressors for the treatment of hypotension in adults with septic or other distributive shock to reduce catecholamine requirements. The FDA approval was based on the use of angiotensin II in high-output shock, known as ATHOS 3 trial, which revealed improved 28-day survival and liberation from dialysis requirement in patients with acute kidney injury requiring kidney replacement therapy at study drug initiation. The drug's long-term effects on lungs, brain, microcirculation, inflammation, and venous thromboembolism risk remain to be determined. At this time, you should be able to discuss the regulation of the classical renin-angiotensin-aldosterone system, pathophysiological roles of RAS, different pharmacologic agents targeting RAS, and special uses of RAS inhibitors. You should also be able to select specific RAS inhibitors in different clinical scenarios and identify adverse effects of RAS inhibitors. Finally, a piece of history for those interested. In the mid-1950s, ACE was identified as the enzyme responsible for the conversion of angiotensin I to the vasoconstrictor angiotensin II. In 1968, studies carried out in the Royal College of Surgeons laboratories of Nobel Prize winner John Vane showed that peptides from the Brazilian viper's venom inhibited the activity of ACE from dog lungs. E.R. Squibb and Sons, now part of Bristol Myers Squibb, got involved in trying to develop orally active synthetic ACE inhibitors. Between 1970 and 1973, Squibb scientists randomly tested about 2,000 chemical structures for ACE inhibitor activity, but could not find what they wanted. Their luck changed on March 13, 1974, when they decided to follow up some newly published research on an inhibitor of carboxypeptidase A, an exopeptidase thought to have a similar active site to ACE. 60 compounds and 18 months later, they had captopril, and early clinical studies confirmed its antihypertensive effects. The 1981 launch of captopril brought fresh headaches for Squibb, as a battery of papers and letters started to appear reporting serious hypotensive effects of the high doses of captopril that were initially recommended. Reporting 4-year data on their first 200 patients treated with captopril, a U.S. group concluded that the initial doses used of 400 mg to 1,000 mg per day were excessive and reported that it was managing most patients with normal renal function on doses of 50 to 150 mg per day. Now that we know better, the maximum dose of captopril is typically 100 mg daily. Congratulations, you're done with this video.